population. In Mulund, I see upper middle class, and in the Vikhroli where I practice, I see upper plus lower middle class as well. The profile changes definitely, but the disease doesn't change.
Okay.
And I see Vikhroli, people are coming because of comorbidities. They are not primarily coming for the diabetes management. They are coming with the comorbidities, like they have a complication, then only they come to you. They do not come for regular follow-up. That is the difference I see from Vikhroli to Mulund. And Mulund is upper middle class where people are aware of the disease, and without complication also they still want to see me every month. They want to see their blood sugar, they want to be on track. So this is what a difference I have made in last 7 years.
You know, this is, I often hear this from diabetologists that only in some cases, most of the cases, it's only after complications that people come and meet a diabetologist. Why does that happen in the first place?
First is, it does matter the economic status also, patient status. Second is the awareness, the education, and overall awareness, even in upper middle class also, is not that great, I would say. Because still they feel they have the common myth about the diabetes. The reason is not because of even they are highly educated, still they are not aware of the disease. And second thing, some cases they feel, the overconfidence kind of a thing. Even sugars on a higher side, the symptoms are not there, and then they do feel, I am not having any symptoms, I may not be suffering from complication. So symptoms are not necessarily present in such patients.
Doctor, in that case, does counseling become a big issue?
It has a major issue. You have to counsel and sit with the patient. Even at time of diagnosis itself, we have to screen patient for the complication. Even if complications are not there, we have to predict the rate of complications. We have to project their lifestyle. We have to project their decades. If they are in 40s, and what will happen in 50s and 60s. But in a better way, counseling has a major role.
Related, doctor, we get a lot of emails where type 2 patients have a huge depression problem. Why does it happen, and what is the way out for them?
Depressions, the thing is, the middle age group population where we see 40s and 50s, it's not necessarily a diabetes itself. The lifestyle what they're having, the stress of the daily activities, their working style, their food habits, and additional to that, they get diabetes. So that's the reason why they have a diabetes related depression. I don't see a diabetes is giving them direct depression. A diabetes is giving a depression to the person who is having multi-organ kind of a complication, is having renal disease, is having retinopathy, he's having cardiovascular complication. He will directly suffer because of these all pathies. He will have a major depression. But not necessarily pure diabetes will lead to depression. It is a basically kind of additive factor. His own lifestyle, his own personal life, his relation with his family, with his working place, and the stress of everyday life gives him depression. I do not agree pure diabetes will give depression to anybody.
Great. Doctor, when it comes to organ failures, what is actually the ratio of organ failure in diabetics according to you? You meet hundreds of patients. So if I ask you, how many people have severe eye problem?
See, documentation is very difficult because the early screening doesn't happen in India. Patients do go to cardiologists more often than the diabetologists. They suffer this coronary vascular disease more often. But point is, if you screen in each and every patient, you will see the microvascular gearing up as earlier than macrovascular. So we get to see erectile dysfunction, the sexual dysfunctions are actually more common than the cardiovascular. But the screening or detection is not there for this kind of a complication earlier. Even retinopathy complications are much more earlier than the cardiovascular one. But still the screening is not available, that's how it is not getting detected. If you see the formation of cataract is much more in diabetic than the non-diabetic population, but still the screening, because patients do not suffer as earlier, so the screening is what is not done. So percentage wise we cannot say only cardiovasculars are more, but I would say microvasculars are more than macrovascular.
But doctor, there are also diabetologists who would say that type 1 diabetics usually get microvascular and type 2 get macrovascular. Would you also believe that?
No, I do not believe. It is only the detection. See how the screening is done. You tend to do only angiographies to see, but nobody doing the retinal FFA. So nobody is doing cavernous angiogram. Everybody is going for coronary angiogram because it is so easy, but nobody is doing cavernous angiogram. So I differ in that.
Okay,
sense.
doctor. There is another issue is about the policies. You treat a lot of diabetics. Now, in your practice, when you go through all these, especially people of economically the lower sections of the society, when you meet them and when they have very serious trouble of meeting their ends, leave alone diabetes and their management, their meeting their ends itself is so difficult. What kind of policy changes from the municipality level to the state level to the central level can actually help diabetics, go for better treatment and better management of diabetes?
Definitely, each of this organization has a major role to play, even in BMC level or state government level or central government level. Especially the availability of healthcare workers, including the doctor who is ready to treat diabetes.
Okay.
In BMC hospitals, if you go, you will not see that kind of approach. It's seen by the common medical officer who is just treating a diabetes as if he is treating cough and cold. That kind of approach is at simple BMC dispensary or simple BMC hospital. State government has the same. Only thing is, state government, they have a bigger hospital, they may have a consultant there who will actually deal diabetes seriously. But again, the burden on him of number of patients and the resources he has. If you go to JJ hospital, they have everything, or the consultants are sitting there, they have a medication in the stock. But the point is, the moral person will not go to the JJ hospital to take his diabetes. He has to go to the BMC hospital or BMC dispensary, where the kind of care is not there available, including the expert doctor there itself, the medication available there, the facilities available for the investigation. In fact, the simple counselor is not there to explain about the diet, explain about the role of SMBG, how it is important to regularly visit. See, they are not charging anything from the patient, but at least they can say, you can come every month, we'll give you the medication, we'll explain you the importance of diet, we'll keep tab on your weight, your blood pressure. Nobody is bothered there. They are just prescribing something and patient is getting something out of it. But the reinforcement is 100% lacking at even simple dispensary level.
Okay.
Which is next door for the any kind of a locality. The reinforcement is zero, absent, completely absent. And now they are saying that BMC will open a clinic, diabetes clinic, even in evening time, so that working class will visit that thing.
True.
But how the daytime is not working, how the night time they will make it available for the, it is most doubtful. So the reinforcement is not at all there. How they are treating malaria kind of aggressively. And they are giving every fever patient, they are giving chloroquine. It is free of cost, and they are doing everything. They are trying to eradicate the mosquito breeding places. No, they are trying to eradicate malaria. We are not expecting to eradicate diabetes, but reach to the point so that the awareness is spread, at least from the education purpose.
Correct, because we have got very successful campaign against polio, against AIDS,
leprosy.
But we are not even started anywhere on diabetes.
No way.
My last point, question will be on erectile dysfunction. What is the percentage of people who get erectile dysfunction amongst your patients? Although that may not be a scientific survey for the first place.
100%. What I see here, more and more people I am screening nowadays. I am getting more and more new views on it, because I feel that every diabetic person should be screened for erectile dysfunction.
Okay.
The way we are doing ECG and mandatory, that it should be asked, it should be kind of a leading question in how your sexual life, anything related. And simple question we ask, simple things. We do not do them hi-fi test for them. And point is, they have this male typical kind of a Indian mentality, where they tend to refuse to talk on this. Sometimes partly they say yes, partly say no. So it's very difficult, but I'm trying to develop some kind of questionnaire, so they do not write their name on it, but just they have to fill and keep it in the box, so that I'll able to understand percentage of ED in diabetic patient. I'm trying to generate.
One email which we have on that issue is erectile dysfunction reversible?
Yeah, 100% reversible, because we have to classify what kind of erectile dysfunction, whether it is organic or just a psychogenic. If it is organic, still there is a lot of things are happening in treatment part, and or psychogenic, it's completely treatable. There's no need to worry. And depends on the.
No, but then when it comes to diabetes, it's usually organic, right?
Not necessary. Sometimes it is a mix also. Not necessary. But obviously years of diabetes has a many major role. 25 years of uncontrolled diabetes, already suffer a macrovascular, then there's a difficulty in reversal. But if you see the other pathies are not there, and we are just talking about erectile dysfunction, I think it is treatable.
Doctor, there are diabetologists who say if you control your blood sugar, your blood pressure, and your lipids, you can avoid all the related disorders. Do you belong to that school?
Partly. I see diabetes is a multifaceted thing. You have to see.
True. Because this is a question which diabetologists have very varied opinion on. Some people say that in spite of your good control, you still might have.
That is very true. I have seen HbA1c being normal, still people suffering from amputation, people suffering from subsequent angioplasties. Throughout 5 years, HbA1c lipid was so low. Still, he suffered a second attack. He suffered a second angioplasty, subsequent bypass. I have seen myself very closely. It's basically a genetic modeling what Indians we have. We tend to follow all these complications, and again there's the thing is where early onset of diabetes has a major role in the life. If you have early decades of diabetes, you tend to have more complications in spite of control of later part.
20 seconds left. Doctor, tell us what's your message for diabetics?
Message for diabetes, you spread awareness about the disease, early detection, early screening. Try to talk more on lifestyle modification, diet. Make patient aware the importance of lifestyle modification and diet is the key role in managing diabetes in the long run. And second is most important is monitoring, which is always missing at all stages. Monitoring is kind of a servicing your own car. How you service your car so often so that car will last long. The same thing with your body. If you do screening, do monitoring on your own, with the help of your doctor, you will survival is more common and the complication will be away from you. If you do that, you will be having more than normal lifespan, more than 65 years of age. You will live 75 year, 80 year, 85 year. But monitoring is not there. You are just consuming tablet and say, yeah, I do the diet. Then again, still you will not be the winner. So this is what my message: more of a screening and more of a monitoring, even in spite of taking medication.
More of screening, more of monitoring for diabetics. Thank you so much, sir, for being with us.